Good afternoon, everyone. Welcome, everybody, to the start of new academic year and to the start of the new citywide grand rounds. The first rounds of the academic year in September are always assigned to the Culture and Inclusion portfolio. So it's my pleasure to welcome you today to the start of the citywide grand medical rounds for the 2025-2026 academic year. We'll start momentarily. We'll give a moment or two for people to join as well. While we are waiting for a couple of more colleagues to join, maybe I can start with the land acknowledgement. So we recognize and acknowledge the presence of University of Toronto Department of Medicine on the traditional territory of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. Today, this land is home to many diverse First Nations, Inuit, and Métis people, and we are grateful to have the opportunity to live, work, and gather on these territories. For those of you who may have heard it before from me as well, pardon me for repeating myself, but land acknowledgement, I think we need to go beyond from a performative acts of land acknowledgement, and these are only a starting point of a conversation. I would encourage all of you to think about from an individual perspective and also with our various professional roles and responsibilities in the Department of Medicine and University of Toronto, how can we be part of reconciliation process and how can we be part of traditional distribution of resources between our First Nation people as well. September 30th is the Orange Shirt Day, so I will just draw your attention to that upcoming important date as well. And just reflect and think about how can we continue to move forward in a meaningful and a productive way to continue our journey of reconciliation as well. It's my pleasure to introduce my dear colleague, and I think many of you know her as well, Dr. Michelle Sholzberg, who is going to deliver her session today. And let me start by introducing her. So Michelle is an adult hematologist and a clinician scientist with focus on coagulation, iron deficiency, and health equity. She's an associate professor and the departmental division director of hematology at the University of Toronto. She's also the division head of Hem-Onc and medical director of coagulation laboratory at St. Mike's Hospital. She is the director of hematology oncology clinical research group and the Heme Equity Lab. Currently, she's involved in the study of prediction tools for perioperative and traumatic bleeding, the intersection of women's health and bleeding disorders, treatments for iron deficiency anemia, and the new treatments for immune thrombocytopenia. So it's my pleasure to welcome Dr. Sholzberg for our Culture Inclusion Faculty Development Rounds for the Citywide Grand Medical Rounds. Over to you, Michelle.
Thank you so much for having me and for the kind introduction. It's really a pleasure and privilege to be here today. And thank you all for joining. I am going to share my screen and you're going to just bear with me for a second as I get it opened up and then flip it because it always does this weird thing. And I have no idea why. Okay. So today I'm going to be speaking about blood loss and iron deficiency and use them both as case studies of structural sexism in medicine. The talk that I'm presenting today is entirely evidence-based. Here are my relevant disclosures. So I have unrestricted research funding from Octapharma and Pfizer, and I've received honoraria for advisory boards from these companies. But probably most importantly, I have a lot of intellectual bias because my clinical and research focus is on all the stuff that I'm going to be presenting today. So I think it's really important, and I hope that you do too. I've also served as a volunteer on a number of different committees, provincially and also now internationally. And also a really important disclosure is that I'm both a bedside and laboratory physician. Throughout this talk, I'm going to use the term women and mothers to highlight the experiences, care gaps for women. And sometimes I'm going to use the term females in reference to the biological capacity to menstruate, become pregnant, give birth, and lactate. I acknowledge that these terms are exclusionary, and I ask you to please recognize that these experiences apply to all people with the anatomy that allows for these things. So I'm going to describe the impact of bleeding on women's health and also the interconnectedness of iron deficiency and bleeding, and then I will review some constructive new directions. So today I'm going to use the most common bleeding disorder and the most common complication of excessive bleeding, iron deficiency, as evidence-based case studies of structural sexism in medicine. But my promise is that this will not be an esoteric discussion. This is entirely evidence-based, and I'm going to show you how this relates to our understanding, framing, and lack of treatment of excessive vaginal bleeding, and also to our conception of what constitutes a normal ferritin and hemoglobin for women. So I will start with this slide, which shows these inextricably linked themes for women of reproductive age. And that's heavy menstrual bleeding, postpartum hemorrhage, iron deficiency, and iron deficiency anemia. And I'm going to start with this man. This is Dr. Eric von Willebrand, who was the first to identify a family of individuals in the Foglo Islands that had a very severe bleeding phenotype. And in fact, the index case was a little girl named Hjordis, and Hjordis bled to death at her 4th menstrual period. Since then, the eponym of von Willebrand disease, for better or for worse, has remained. But despite it retaining its eponym, it is in fact the most common bleeding disorder on Earth. And von Willebrand factor, as you know, is a hemostatic bomb that is made and stored in platelets and endothelial cells. And the image to the right is showing you an endothelial cell. The blue is the nucleus, and all those little green dots are von Willebrand factor. So our endothelial cells are just chock full of VWF. Ready to be right where it needs to be in the face of trauma. And when there's deficiency or dysfunction of von Willebrand factor, which is this large hemostatic glycoprotein, both primary and secondary hemostasis are affected, and excessive vaginal bleeding is the most common symptom. Now, I'd like to speak about the impact of von Willebrand disease and all bleeding disorders on overall health and well-being. I'd like to warn you that I may show some images over the course of this presentation that may make you feel uncomfortable. And I think it's okay for us sometimes to feel uncomfortable and also to ask ourselves and to reflect why we feel uncomfortable. So some of the images I'm going to be showing you are things that we don't often share in the world at large and not even in medicine. So here's the image. We're not accustomed to seeing saturated pads and tampons with vaginal blood. It's just not something that has been normalized, and we are not desensitized to it. Now, gynecologic and obstetric complications in people with von Willebrand disease is extremely common. And up to 95% of women with VWD have heavy menstrual bleeding. It's so common, in fact, that when a person with von Willebrand disease or someone that's referred to clinic and they're described as having von Willebrand disease doesn't have heavy menstrual bleeding, I in fact question the validity of the diagnosis. But other types of vaginal blood loss is very common in this patient population, including excessive bleeding after miscarriage, during pregnancy, after labor and delivery, and also miscarriage itself, which may be more common in this population. And so over the course of my career thus far, I really dedicated a lot of our work towards understanding the experiences of women with bleeding disorders. And this study, which was led by Dr. Arya, was one of the first publications on the topic, which was published in 2020, to understand the lived experiences of women with inherited bleeding disorders. And she conducted a qualitative study. And 15 different women were included in this study with a series of different bleeding disorders. And the themes that emerged through her work was conceptualization of experience through family bleeding, uncertainty surrounding the diagnosis, intensity of bleeding symptoms, and impact on identity and daily life. And I quote, "When I started my period, I wasn't sure what was normal or not." This work that was led by Dr. van der Meulen evaluated the experience with postpartum bleeding among women with inherited bleeding disorders, because we asked ourselves in clinic, can women with inherited bleeding disorders who've bled heavily for their entire reproductive lives effectively identify excessive postpartum bleeding? And this was published in 2019. And what she found was missing dialogue surrounding communication of postpartum bleeding and expectations, and normalization of excessive bleeding with a skewed frame of reference regarding vaginal blood loss. And I quote, "I didn't have to call an ambulance. I wasn't in and out of consciousness. Those are my opinions of true hemorrhages, but it wasn't like that with my delivery. And as far as I'm concerned, it's completely normal to have heavy bleeding after a delivery." So through this work and the work of other groups, these themes of normalization and desensitization kept coming up. And if we acknowledge that up to 95% of women with von Willebrand disease, the most common bleeding disorder on earth, experience heavy menstrual bleeding, 70% of them report normal menstrual bleeding, despite having measurements in keeping with heavy menstrual bleeding. And that's because people often gauge the normalcy of all of our experiences, including our experiences with vaginal blood loss, by referencing our own personal experiences and our family experiences. And when you're referencing family members who also have abnormal bleeding, heavy vaginal bleeding becomes normalized and generations become desensitized. Moreover, the stigma surrounding menstruation obstructs conversations about vaginal bleeding with non-relatives. I am here to say that despite my career focus on the area, that I don't sit around with my friends talking about my period, and I never have. Additional work led by Dr. Aria is this that describes barriers to care for women with inherited bleeding disorders. And I quote, "They don't really take my bleeds seriously." And the themes that emerged here was lack of healthcare provider awareness of inherited bleeding disorders, healthcare provider dismissal of symptoms, limited access to care and treatment plans, and the need for self-awareness and advocacy. And you have to be prepared to be the advocate because you can't rely on them to know what you're talking about. Now, despite von Willebrand disease, as I said, being the most prevalent inherited bleeding disorder, diagnostic delays and misdiagnoses make timely identification and management very challenging for this patient population. In fact, the average time from first symptom to clinical recognition is 16 years. And these delays on average are 6 years longer for women than they are for men. And even if a patient identifies abnormal bleeding and presents to medical attention, they frequently experience dismissal, leading to serial misrecognition and healthcare-related trauma, which decreases the likelihood that they're going to present again. Now, the cycle of sexism in the management of bleeding disorders is now acknowledged, and this commentary by two colleagues, Drs. James and Wyand, describe that the lack of knowledge and comfort that patients and healthcare providers have in discussing vaginal bleeding leads to only 4 in 10 women with heavy menstrual bleeding seeking care, and despite von Willebrand disease being 10 times more common than the hemophilias across all severities and types combined, it has significantly fewer resources devoted to it. But today, I'd like to show how this impact extends far beyond patients with bleeding disorders. And so now I'm going to speak about heavy vaginal bleeding in general among all women. So what are the facts? The prevalence of heavy menstrual bleeding has been described in the literature as ranging between 15 and 61% of all women. A more recent estimate, in fact, a more accurate estimate, and robustly designed study estimates that 50% of all women have heavy menstrual bleeding. But defining heavy menstrual bleeding is really challenging. It is defined as menstrual blood loss of greater than or equal to 80 milliliters of blood lost per cycle. I stand here as a woman of reproductive age, and I will tell you, I have no idea how to operationalize that. So if we use for reference the amount of liquid that we're allowed to take on a plane for carry-on, that's 100 milliliters. So greater than a bit less than that meets the definition of heavy menstrual bleeding, but over the course of a person's entire menstrual cycle. Now, what's really important is never to ask our patients, do you have heavy menstrual bleeding? Because a person who's bled heavily their entire reproductive lives doesn't know the difference between normal and abnormal bleeding. So with that question, we're just inviting the patient to lead with their bias. So how do we quantify heavy menstrual bleeding? There are a few methods available. There's the alkaline hemotin method, which is a historical method that involves actually chemically measuring the amount of blood in used menstrual products. It involves bringing your used pads and tampons in for assessment. This approach has been deemed unacceptable to research participants. There's also the pictorial blood loss assessment chart, or the PBAC, which provides a pictorial representation of how saturated a pad or tampon is over the course of a person's cycle. And with increasing saturation, more points are accrued. And then all of the points over a person's menstrual cycle are added up, and a score of greater than or equal to 100 is equivalent to about greater than or equal to 80 milliliters of blood loss. Now, the original work on the PBAC was published in 1990. There are, of course, menstrual cups that directly quantify the amount of blood that is lost. And there are also bleeding questionnaires or bleeding assessment tools that provide some guidance. But all of these are visual, quantitative, or semi-quantitative measurements. Now, the bleeding history is the most important test of hemostasis, and these validated questionnaires or bleeding assessment tools, or BATs, provide some guidance on how to ask about vaginal bleeding. And so, for example, this is one of them. It takes you through each different bleeding category and the more medical or surgical intervention that is required to control bleeding, the more points that somebody accrues. But what is really important here is that there's the assumption that an individual has access to healthcare. So only if a person was prescribed tranexamic acid or contraceptives for the management of heavy menstrual bleeding, or provided with iron supplementation for secondary iron deficiency or iron deficiency anemia, will they have an opportunity to accrue more points in that category. This work, which was led by my colleague, Dr. James in Kingston, was the first study since 1990 validating the original PBAC using modern menstrual products. So what has happened over the last few decades? Menstrual products are designed to hold more blood, to be less disruptive to a person's life. That means that the historical PBAC underestimates the amount of blood that is in fact lost because our products have evolved over time. This work was published in 2021 and in the highly subspecialized Journal of Hemophilia. That, unfortunately, I believe is another flag indicating how deprioritized this type of really important work is in medicine, because I know very much so that this work was submitted to other higher impact journals where the readership was more generalized. The bottom line is people that work in the space of bleeding disorder are not the people that need to be reading this paper. Also, work that was led by colleagues in Oregon tells us that menstrual products being used as a surrogate for heavy menstrual bleeding is fundamentally flawed. And until their work that was published in 2023, the true amount of blood that was contained by various menstrual products was unknown because they were historically tested using saline. And we are all familiar with the commercials showing us how much blue liquid a pad or tampon can hold. We can acknowledge as healthcare providers that the viscosity of saline is very different from the viscosity of whole blood. And so they assessed modern day menstrual products using expired units of red blood cells. And they found that the amount of blood held by different products varies significantly, ranging between 2 milliliters to 61 milliliters of blood. And in fact, saturation of 2 heavy pads is equivalent to 100 milliliters of blood loss, or 3 heavy tampons is equivalent to 90 milliliters of blood loss. So right there, it's very possible that many of our patients meet the definition of heavy menstrual bleeding in just a few hours. So if clinicians are relying on the frequency of product changing alone without asking about specific products or the types of products that people are using to diagnose heavy menstrual bleeding, we are missing a significant amount of women. Now, the definition of heavy menstrual bleeding has since been refined by the von Willebrand disease 2021 guideline panel. And they have aligned this definition with the American College of OBGYN. And they say that this is a period that lasts more than 8 days, soaking through 1 or more pads or tampons every 2 hours, needing to use a pad and tampon at the same time, changing in the middle of the night because gravity is usually helpful, repeat passage of blood clots, or a PBAC score of greater than 100. But you'll notice that the types of products used is not mentioned here. Now, the International Federation of Gynecology and Obstetrics, or FIGO, has this as their definition of heavy menstrual bleeding, and that's excessive menstrual blood loss that interferes with a woman's physical, emotional, social, and material quality of life. Now, this focus on quality of life is obviously so important, and I'm all for it, but unfortunately, this definition is too amorphic and not helpful when I'm working with a learner in clinic. I need to be able to give people something objective and helpful when they're evaluating a patient in clinic. Moreover, this definition is deeply connected to believing and validating the patient, and I've shown you thus far that healthcare provider dismissal is a core theme for patients who experience heavy vaginal bleeding. So now I'm going to move to postpartum hemorrhage. So what are the facts here? So every year, 14 million women experience a postpartum hemorrhage, and that accounts for 70,000 maternal deaths. Postpartum hemorrhage is the #1 cause of maternal death, and Black women are 3 times more likely to die of a postpartum hemorrhage than white women in the United States of America. And when women survive, they often need urgent surgical interventions to control the bleeding, and they may be left with lifelong reproductive disability. So what are the definitions of postpartum hemorrhage? Well, a primary PPH occurs within the first 24 hours of childbirth, greater than 500 milliliters for vaginal delivery, greater than a liter for a cesarean delivery. And this definition was proposed by a WHO working group in 1989. And it uses the same threshold for all women, irrespective of maternal anemia, despite recognition in 1989 that an alternative definition was needed. Now, when it comes to the bleeding that occurs from 24 hours to 6 to 8 weeks postpartum, I wish I had estimates for you. It's essentially a black box. Now, this work that was led by Dr. Siad evaluates the experience of all women experiencing heavy vaginal bleeding, bleeding disorder or not. And the reason why she worked on this is because there was a lack of robust scientific literature on this. Here's a snapshot view of her table 1. All individuals that were included in this study identified as a woman. We were very purposeful to ensure that we recruited a diverse group of individuals. It just so happened that this was a very educated group of people. That wasn't deliberate. And if you'll notice, the duration of bleeding symptoms for everybody was really long. The shortest amount of time was 3 years before they were diagnosed. And so when Dr. Siad asked, walk me through your experience with excessive vaginal blood loss and when you first noticed your symptoms weren't normal, and I quote, "That has been my life. I just didn't understand how these period products are for a full 8 hours. I can't even sleep for a full 8 hours without having to get up to change." Has knowing there's a name to it, meaning heavy vaginal bleeding, and treatment for it changed the way you live? I am now able to be a functioning person. I thought that I was supposed to be incapacitated for days. I thought everyone was incapacitated. How can we do better? I was a bedside nurse in a hospital for approximately 10 years. We asked people about their bowel movements daily. We asked people about their voiding daily. We asked people about how many cups of water they drink in the hospital. Why can't we ask them about their menstruation that day? It's a thing that just over half of the world lives with, and it shouldn't be taboo, but it is. I have since learned that the term taboo has many meanings, and one of its meanings, it's a Polynesian word, in fact, directly references menstruation. It's not helpful to the person to be blamed for something that is happening to them physically or biologically. The one thing so important as a Black woman is being believed. There is so much power in just believing someone. Now, Dr. Siad conducted a separate study because we knew that there are widespread knowledge deficits and lack of comfort between patients and clinicians in openly discussing vaginal blood loss. Medicine is a culture like any other culture, and we have to acknowledge that we're not very comfortable talking about vaginal bleeding in medicine. But it was unclear the extent to which medical trainees, or staff for that matter, can confidently recognize signs and symptoms of heavy vaginal bleeding. To our knowledge, Dr. Siad conducted the first study to assess medical trainees' understanding, attitudes, and feelings regarding vaginal bleeding. 73 medical trainees at the University of Toronto were included, ranging across a variety of different specialties. So when we asked their general feelings and comfort levels surrounding vaginal blood loss and its diagnosis, they responded with strongly agree, the green, to strongly disagree, the red. I'm comfortable diagnosing excessive vaginal blood loss. Most people are pretty comfortable. I'm comfortable diagnosing a primary postpartum hemorrhage. Again, people are relatively comfortable. And there's starting to be some discomfort surrounding the diagnosis of secondary postpartum hemorrhage. When we asked, I'm aware of the following tools that quantify vaginal bleeding. 21% of people had heard of the PBAC. 56% had heard of bleeding assessment tools. 1.5% had heard of the alkaline hematin method, which is totally fine. And 51% had heard of menstrual cups. That means that in this cross-section of medical trainees, 49% of people had never heard of a menstrual cup. And when we asked them in assessing vaginal bleeding, I've used the following tools, and you'll notice they were basically not using any of these tools. So we found that while a broad range of medical learners described themselves as largely feeling comfortable with their skills in assessing vaginal bleeding and being aware of tools to facilitate the diagnosis, surprisingly few had used these tools in clinical practice. And we believe that these findings highlight knowledge and skill gaps surrounding vaginal blood loss, but interestingly shows excessive confidence in its diagnosis amongst medical learners. Now, really importantly, I am not pointing a finger at the learners. In fact, I think if anything, these findings are totally attenuated because I think this group of people was probably really motivated in completing a survey about vaginal blood loss. I don't think it's their fault. I think this excessive, unusual, and pervasive confidence reflects a structural problem. And I'm going to read this quote on balancing confidence and humility in the diagnostic process that was published in the Journal of Diagnosis in 2019. Humility in medicine can be difficult to achieve, yet arguably is one of the most important competencies to master. Overconfidence, on the contrary, is a natural tendency, having established its roots in evolution, where quicker and more confident decisions likely conferred a selective advantage. Humility may evoke an image of weakness and vulnerability antithetical to contemporary medicine, whose culture is dominated by overconfidence. Nevertheless, humility can be learned and is important because overconfident behavior can be detrimental to our patients medically, psychosocially, and legally. To practice humility requires strength and emotional resilience. So this brings me back to these inextricably linked themes. And I'm going to remind us all of the Woman Trial. The Woman Trial was a large randomized controlled trial comparing tranexamic acid with placebo for the management of postpartum hemorrhage. 193 hospitals participated in this study in 21 countries, but the majority were recruited in Africa and Asia. Now, this was a negative study with regards to the primary outcome, which was mortality or hysterectomy. However, tranexamic acid reduced the risk of one of its key secondary outcomes, which was hemorrhagic death, especially if provided early. Why am I talking about this trial? I'm talking about this trial because of the subsequent qualitative study that emerged after the trial was completed. And as part of this study, they collected narratives from over half of the obstetricians that cared for the women who died in the Woman Trial. So there were 483 maternal deaths. 3% occurred in Africa, 375 women, and 1.7% in Asia, 105 women. In Europe, where 1,049 women were recruited, none of them died. And what were the themes that emerged? Unfortunately, was not able to get blood transfused. She died because of severe blood loss and pre-existing anemia and lack of more blood for transfusion. She died because we could not replace all that she had lost. The main cause of death was the anemia, which became complicated by heart failure, from which she never recovered. So a core theme here leading to hemorrhagic death is antenatal anemia, an anemia that could not be acted upon. And that's because blood was often unavailable due to shortages or because it was not affordable. So this brings me to the next inextricably linked theme, and that's iron deficiency and anemia. So anemia and non-anemic iron deficiency have important consequences. We all know that iron deficiency anemia is bad. We all know it is associated with severe morbidity, blood transfusion, and death. In fact, data from NHANES shows that age-adjusted mortality rates with iron deficiency anemia as the underlying cause of death has increased over time, despite death from other causes of anemia decreasing by more than 25%. And I'm going to show you a little bit later why people think that is. But non-anemic iron deficiency matters too. It's also associated with negative things, including neuropsychological manifestations like pica, restless legs, abnormal mood, and low IQ due to the negative impact on memory, attention, and thought processing speed. It's also independently associated with risk of blood transfusion and risk of death. A German cohort study of healthy people between the ages of 35 and 74 found that there was an association between absolute iron deficiency and mortality after adjustment for hemoglobin and major cardiovascular risk factors. So of course, I'm standing here as a hematologist who's very focused on the bone marrow and the red blood cells. But iron is important for so many bodily functions, including myoglobin, including our Sept enzymes in the liver, including it being a cofactor for the synthesis of serotonin and dopamine. Now, the challenge of iron debt is real for women of reproductive age. With a normal period, a person loses 10 to 20 milligrams of iron per menstrual cycle. And when heavy menstrual bleeding is present, more than 40 milligrams of elemental iron is lost per cycle. And when iron losses chronically outpace iron intake, iron deficiency develops. Now, the recommended iron intake per day is 18 milligrams with a normal period. The average intake in the United States is between 12 and 13 milligrams per day. And that's the hypothesis as to why iron deficiency anemia as the cause of death in the United States is on the rise. Now, it takes about a gram of iron to make a baby, to increase maternal blood volume, to make the baby itself, to make the placenta, and to account for local losses. And I know that a gram of iron doesn't sound like a lot, but a gram of iron is equivalent to 177 large steaks. It is fundamentally impossible to eat that over the course of your pregnancy. Now, we know that maternal mortality is associated with anemia. So individuals with a hemoglobin below 70 in low and middle income countries have a 2.36-fold higher odds of maternal death. But does that matter to us here in Ontario, Canada? It does. And this work that was led by Joel Ray at St. Mike's using ICS data looked at nearly 1 million women in a retrospective cohort study where they wanted to evaluate for association between severe maternal morbidity or mortality from 23 weeks gestation up to 42 days after index birth. And what they found was that a low maternal hemoglobin in early pregnancy was associated with a greater risk of severe maternal morbidity, mortality, or red blood cell transfusion. Now, really importantly, this risk was higher even at hemoglobin values between 110 and 124, which is above the threshold to define anemia in pregnancy or the recommended threshold to initiate iron therapy. Now, iron deficiency is cyclical, it is compounding, and it is intergenerational. And there is the cycle of oppression that occurs. And that is because iron-rich foods are expensive. Access to care is heavily influenced by variables associated with vulnerability. And also because mothers who give birth to babies, and if they have anemia at the time of their pregnancy, those children in their early school years have a greater risk of autism spectrum disorder, ADHD, and intellectual disability. So iron deficiency affects the most vulnerable, but it's also vulnerable making. Now, this work, which was led by Dr. Tang, confirms that finding. So if you didn't believe it, this is data from ICS, and it confirms that in over 1 million births, we observed a greater risk of autism spectrum disorder among those with early pregnancy hemoglobin concentrations below 115 and also above 135. This work that was led by Dr. Shams also found an association in Ontario using ICS data, now looking at hemoglobin concentration in mothers in early pregnancy and severe neonatal morbidity and mortality. And what she found is the same thing, another U-shaped curve, that a hemoglobin concentration below 110 and greater than 135 were associated with increased risk of severe neonatal morbidity and mortality. I think what's really important to acknowledge, though, is that oral and intravenous iron replacement for people with iron deficiency, anemic or non-anemic, can improve iron deficiency and iron deficiency anemia with an exceedingly low probability of overcorrection of maternal hemoglobin above 135. Thus, we believe that treatment guidelines should continue to endorse the use of iron in women with iron deficiency anemia in pregnancy. It just doesn't work like that. The bone marrow doesn't work like that. You don't just give it more food and it doesn't give you a hemoglobin of 150. Now, if we look at the global prevalence of iron deficiency anemia, 33% of the world has iron deficiency anemia. In some parts of the world, it's estimated as up to 65%. This work that was led by Dr. Wen describes the prevalence of iron deficiency in the province of Ontario in non-pregnant females of reproductive age. 40% had non-anemic iron deficiency, 13% had iron deficiency anemia, and of those with iron deficiency anemia, 56% had a normal MCV. So it's time to dissociate the story of microcytosis. This work that was led by Dr. Teichmann, similar study, but now looking at pregnant patients, she found that iron deficiency affects more than 50% of pregnancies in early pregnancies in the province of Ontario, but 40% of pregnant women didn't have a serum ferritin done. And in fact, females of lower socioeconomic status have lower odds of screening for iron deficiency in pregnancy, despite having a higher risk of iron deficiency anemia in our universal health services system, where serum ferritin testing is completely covered. At St. Michael's Hospital, we found that 77% of women at labor and delivery had iron deficiency at birth if we're using the threshold of 30, and 92% if we're using the threshold of 50. So this is the original pandemic. But how? This is one of the few things in medicine that we can actually treat. That's because it's structurally sanctioned. So WHO guidelines suggest that iron deficiency is diagnosed with a serum ferritin of below 12 or 15. So Dr. Churong evaluated the origin of serum ferritin reference intervals using a systematic review. And what she found is that while all of these studies were looking at apparently healthy individuals, essentially very few of them assessed for clinical historical or laboratory parameters of iron deficiency or risk factors when defining normal. So existing serum ferritin reference intervals are at high risk of bias, which led us to the belief that evidence-based clinical decision limits is the way to go. So what does the evidence tell us? Well, since the 1990s, we've known that a serum ferritin of less than 30 is generally accepted as the threshold to mark iron deficiency in adults. But there is data, also dating as far back as the 1990s, and also more contemporary data that suggests a progression to iron deficiency, and that in fact, GI absorption of iron returns to baseline when the serum ferritin is above 50, as do other biochemical markers of iron deficiency normalize above 50. But there's an important elephant in the room. And so if we have any clinical or medical biochemists on the line, you know what I'm about to say. And that's, what about the variability across different ferritin assays and the lack of standardization? Now, this is really important. So the Institute for Quality Management and Healthcare is our provincial lab proficiency and quality testing body. I had the privilege of working with them for 9 years on their hematology scientific committee. And this survey was distributed to a bunch of labs in Ontario. And in Ontario, as well as other out-of-province labs, to understand how labs manage reference interval and post-analytical reporting of ferritin. The most common instruments and reagent kits were represented in this survey. And what I'm showing you here is that depending on the type of assay and instrumentation used, there's variability in the serum ferritin that is reported, especially at the high end, much less variability at the low end. But it's important also to acknowledge that we're evaluating for two completely disparate disease processes at the low end and at the high end, despite using the same laboratory analyte. So presented a little bit differently, if you look to the graphic on the right, on the y-axis, it's looking at percent difference from the all methods mean. And on the right, we're looking at the all method mean ferritin for a given assay. And so there is variability at the low end of about plus or minus 30 to 40%. So for example, if the all methods mean for ferritin is 10, the range across labs is going to be 7 to 14. If the all methods mean for ferritin is 30, the range is between 21 and 42. So the bottom line, all within the clinically accepted range of iron deficiency. I haven't even yet talked about the diagnosis of anemia, and this is what the WHO suggests, that we use sex-based hemoglobin thresholds to diagnose anemia, as well as different thresholds in pregnancy across trimesters. But these sex-based thresholds were first adopted by the WHO in 1968 on the basis of 4 published references and 1 set of unpublished observations. This work that was led by Dr. Blitt Hansen and Vidushi Swarup, which is a systematic review looking at where's the data on sex-based hemoglobin thresholds to diagnose anemia. And in summary, iron deficiency has really generally not been considered as an important determinant of hematological health when defining sex-based anemia thresholds. This work led by Dr. Giuliano, similar systematic review looking at pregnant people, it's even worse. Iron has essentially not been considered. B12 wasn't even a second thought. So a ton of work is ahead of us. So this really is a structural problem that requires structural solution. And this led us to an initiative called Raise the Bar, which is the move away from serum ferritin lower limit of normal to a clinical decision limit. So what are the facts here? Iron deficiency and iron deficiency anemia is the original pandemic. It's the #1 micronutrient deficiency globally. It disproportionately affects women and children. Non-anemic iron deficiency affects 40% of women of reproductive age in Ontario and up to probably 100% in some parts of the world. Iron deficiency anemia affects 12% of women of reproductive age and probably 80% in some parts of the world. Iron deficiency anemia affects 2 billion people annually. It is the leading cause of years lived with disability in women worldwide. It is associated with severe neonatal, maternal morbidity and mortality, as well as enduring neurocognitive abnormalities. Serum ferritin thresholds are at risk of high risk of bias. And this lower end of ferritin has an all methods mean variation of plus or minus 30 to 40%. And subsequent work confirmed that people are more worried about the risk of false negatives than the risk of false positives in this acceptability survey, where we sent out a survey electronically and on social media to ask healthcare providers, are you worried about moving to a clinical decision limit that would flag a serum ferritin as abnormal for less than 30 in adults and less than 20 in pediatric patients, and that's where the data lies for pediatric patients. And 80% of people said they're not worried. And of those who said they're worried about it, they were worried about these thresholds still being too low. So this led us to Raise the Bar, which is an example of structural change. And so now at Life Labs and Dynacare, which are the largest community laboratories in Ontario and also in the remaining provinces and territories in Canada, we have moved to clinical decision limits. Now, clinical decision limits are very common in medicine. We're all familiar with the D-dimer clinical decision limit and lipid panel clinical decision limits. So this is no different. So now this is what you will see. It will be flagged as abnormal, and it will bring you to a website that we all developed together to teach clinicians how to further walk through the management process of a person with iron deficiency. So structural change is needed to change behavior, especially in absurdly prevalent conditions like this one. I think we'd be hard pressed to find a condition that's so prevalent. And this abnormal lab test result flag has previously been shown to reduce care gap risks. It was important to couple this with knowledge translation, and so this website was developed with lots of input from relevant stakeholders. These are the memos that were sent out by Life Labs and Dynacare, and also from various hospitals. And this is the memo that was sent out by Ontario Health with their new branch, the Ontario Lab Medicine Program. The opportunity for impact is huge. These companies serve a ton of people. It took us 4.5 years to get here. I didn't do any of this alone. All of this was voluntary work, and we met monthly, and this experience was recently published. What kept us going? The evidence, our patients, our frameworks, what's right, and goodwill. And I quote, would the world ever allow for the passive acceptance of lab screening definitions that came with the slightest risk of diminished opportunity to address a correctable condition associated with white male mortality, morbidity, and decreased productivity? We must make structural changes for all women and children, but especially those who continue to experience oppression within the healthcare system, which is simply an extension of oppression existing outside of it. So I'm very grateful for the move away from frankly unfeasible vaginal bleeding assessments and these relatable, modern, qualitative assessments that consider the impact on quality of life. The WHO setting iron deficiency anemia as a key global health priority for 2025. We didn't quite get there, but just the fact that it was acknowledged as a big problem is really important. I'm grateful for the opportunity to raise the bar and all of the people that I got to work with over the 4.5 years, and the many existing efforts focused on research and knowledge translation in women's health. I'm very grateful to ASH for all of their efforts in this space, including their guideline efforts. Their guideline on the diagnosis of iron deficiency is expected to come out in early 2026. There are existing other recently published guidelines. This is out of a group in Oregon. I'm very grateful to First Exposure, the new mother risk, for acknowledging this as an important problem. I'm very grateful to all of my colleagues in the city who are moving away from normalization of anemia and suggesting that pre-op hemoglobins of 130 or higher should be targeted for everyone, irrespective of their sex. So these themes are predicated on a backbone of health inequity, structural discrimination, normalization, desensitization, stigma, bias, myths, and period poverty that I didn't even have a chance to talk about. And I'm going to read this out now, and these are all evidence-based statements. The more you bleed, the more iron deficient and anemic you become. The more anemic you are, the more you bleed. The more you bleed, the more likely you are to miss school and work. The more vulnerable you are, the more likely you are to receive the less likely you are to receive care and to achieve success. And the more unaddressed your heavy menstrual bleeding is, the more anemic you are in pregnancy, and the more likely you are to have a postpartum hemorrhage and die. It is time to reframe our concept of normal. Heavy vaginal bleeding isn't normal. Our patients often can't distinguish between normal and abnormal vaginal bleeding. Medical learners are inappropriately confident in diagnosing heavy vaginal bleeding. Having iron deficiency isn't normal. Having iron deficiency anemia isn't normal, and both should immediately prompt dialogue about vaginal bleeding. Our current structures permissively lead to normalization, desensitization, and dismissal of heavy vaginal bleeding, iron deficiency, and iron deficiency anemia, and these impacts are intergenerational. Knowledge translation and exchange, which includes guideline harmonization to provide one clear message, is our way out of this oppressive cycle, and I believe strongly that tackling this is our responsibility. Again, as I said, I don't do anything alone, and there are a million people to thank, especially my patients. Thank you.
Thank you so much, Michelle. What a thought-provoking rounds, which did push us out of our comfort zone, but it's only by being pushed out of our comfort zone that we learn new things as well. So thank you for challenging us and giving us an opportunity to reflect as a clinician, as individuals, as academic physicians, and as leaders. The questions are starting to come already, and maybe because I'm facilitating these rounds, I will take the first one. Thank you for sharing this statement around humility and overconfidence. And I must say, humility is not acknowledged in medicine. Oh, sorry about that. I'm at Sunnybrook. So maybe we can take a question from the chat, which is asking you to comment on the connection between the autism and iron deficiency anemia.
Thanks so much. I love that quote too. I love the connection between humility and emotional resilience. I thought that was brilliant, which is why I read it. And it's not something that I really thought about, but it resonated for me. Okay, so the connection between autism spectrum and iron deficiency anemia. So it's really important for me to acknowledge the limitations in the data that we have. First and foremost, 50% of individuals that were included in that cohort study, we did not have serum ferritin values for them. Okay, so if I'm being asked what is the association between iron deficiency and autism spectrum disorder, I cannot comment. But if I'm being asked what is the association between maternal anemia early in pregnancy and autism spectrum disorder, I can say there is certainly an association, and iron deficiency is the #1 cause of maternal anemia, and it's also correctable. So I'll stop there.
Okay, thanks, Michelle. There's a question from Barry Golis who is asking, do we need to automatically give pregnant women iron as well as folic acid? I mean,
Such a great question. And you're kind of alluding to how do we tackle this? Do we have to tackle this like in the same way that we tackled folic acid deficiency with a public health campaign? And I believe, yes, we do. Should we be giving it automatically to all people? The answer is we should be doing a serum ferritin check early in pregnancy. That's the true question. There was very recently a study that was published showing that when a serum ferritin is below 60 in early pregnancy, that predicts a serum ferritin below 10 later in pregnancy. So myself and a group of other academics in Toronto put forth a guidance document that's on our website, and we suggest when the serum ferritin is below 50, and frankly, based on what I just said about the variability between ferritin assays, I think that's totally acceptable. But when it's below 50, yes, please start patients on oral iron supplements.
I'm trying to follow the order the question has come. So I'll go to Lauren's point and then we'll go to Jackie because she has raised her hand as well. And thank you, Lauren, for sharing your personal experience as well, like struggle to get IV iron supplements and how hard it is to move the needle with oral and how it affects patients, especially who have GI side effects or people who have celiac disease or malabsorption disorder. And can we improve access to IV iron?
Great question. Thanks, Lauren. And you're right. It impacts our patients, including us. I have a massive patient population of female healthcare providers and male healthcare providers who've had difficulty in accessing intravenous iron. The challenges with intravenous access to iron is complex and also highly structural. Part of the challenge within hematology is the unfortunate comparison and battle between malignant and non-malignant hematology in accessing infusion chairs, which is really unfortunate, and it should never be positioned in such a way. But that is a real challenge for cancer centers, which is why it is so hard to access those chairs. Additionally, of course, there are private infusion clinics, but those private infusion clinics can cost an additional $200 to $300 just to get the infusion on top of the drug cost. And there's also variability in access to coverage for the cost of the drug. So there's a whole group of individuals falling into the category of the working poor who don't meet criteria for public assistance, who don't have private insurance, who can't pay out of pocket, but who are at risk for iron deficiency and can't get it. So how hard it is to move the needle, it's hard. We're working on it, myself and lots of other people. And I hope that over time we will improve access.
Jackie?
Thanks, Michelle. That was really an outstanding presentation. And it's making me feel like I'm underperforming in my ambulatory clinic. because as an endocrinologist, of course, I see a lot of women of childbearing years, much as family physicians would in primary care. And so the question to you is, you've really, beautifully highlighted probably what is even a pre-pregnancy deficiency, going back even before there's pregnancy planning. Those of us who see individuals who are planning to become pregnant but may have a high risk pregnancy, and we definitely have not been screening ferritin. I can tell you, we tell everybody to go on folic acid. We tell them all to, once they're past the first trimester, to get on to Materna and other pregnancy supplements, but definitely do not screen with the ferritin. So can you comment on actual screening and what the recommendations would be to primary care? Because this is really where this is going to happen as a change.
Thanks, Jackie. You've asked so many really, really important questions there. So myself and many other people developed a website to address exactly what you're saying. And in fact, we worked with family health care providers specifically to develop the website, and it's designed after one of their most commonly used websites to look exactly like what they're used to using, so to maximize its usability and impact. So what are appropriate thresholds that we've indicated on that website? I can't speak to what the ASH guidelines will come out to say, but I imagine them being aligned. A threshold below 30 is diagnostic for iron deficiency in adults. Below 20 is diagnostic in pediatric patients. If you have an individual with concomitant inflammation, which may be some of the patients that you're taking care of in your endo clinics, then you need to rely on serum transferrin saturation. But what's most important is that when you're checking iron studies, which includes the serum iron, TIBC, and transferrin saturation, is to test that in the fasting state, because transferrin only binds to 2 iron atoms at a time. Ferritin binds to thousands of iron atoms. So ferritin is not affected by what somebody just ate. Transferrin is and can be falsely oversaturated. So you tell the patient, don't take your prenatal vitamin, don't take your iron supplement, and please don't eat your breakfast before you get your iron studies drawn, and just focus on the TSAT. Less than 20% is absolutely diagnostic.
Mm-hmm. Okay.
And I just want to say one other thing, sorry, because Jackie, you talked about prenatal vitamins. 98% of prenatal vitamins are not the solution to iron deficiency. And that is because they're complexed with divalent cations like calcium and magnesium that directly interfere with the absorption of iron. So that's it's not a solution.
It's 12:59. I'm pretty sure we will not be able to answer all the questions. But maybe, Michelle, you can share the website in the chat as well. And I see some hands raised as well. And pardon me, Angela, and pardon me, Blair. I don't think we will be able to answer those questions, but you did answer some of the questions in the chat. Maybe in the last 1 minute, if you can talk about the best oral supplements and people who have dietary preferences, what they can take. There was a couple of questions about that. Different iron salts versus vegan, vegetarian. Yeah.
Thanks for repeating it, because I was like typing and I was half listening. So, okay, if anybody tells you that they know which iron supplement is the best one to take, they're lying to you. Nobody knows. No idea. This is the most common condition on the face of the planet, and we don't have a handle on first-line therapy. So that in and of itself is a really big statement. I don't know. The truth is, though, what I know is that there is some suggestive evidence that less is more. And so I never give a patient an oral iron supplement more than once a day, because there is mechanistic evidence that giving more interferes with the absorption of iron as well as its recycling. So less is more. I believe the best oral iron supplement is the one that your patient can tolerate and take consistently.
I think that's a good closing statement. So let me draw these rounds to close. Thank you so much again, because I think when we think about EDIA, sometimes we have a very narrow focus and we are thinking about the very small bit of things in our educational and academic and healthcare settings. And I think you just shared with us how important it is to diagnose and to identify structural racism and bias to deliver person-centered and patient-centered care. So thank you so much. We really appreciate your wisdom and insight. And thank you, everybody, for being okay with not having your questions not being answered. So we'll draw these rounds to conclusion. And there is Ramona posted a link to evaluate these rounds. So please do so as well. Thank you so much.
Thank you. Thanks for having me.
Thanks, Michelle.